Good day to our listeners. Today is Friday, July 8th. My name is Kaku Barkoh. I'm a member of the Public Affairs Committee for the North American Spine Society and a practicing orthopedic spine surgeon in Houston, Texas. I'd like to welcome everyone to our next installment of our podcast series, showcasing interesting articles from SpineLine, NASA's membership magazine. Today, we'll be discussing the article by Jacob Razzouk, Omar Ramos, Nathan Schilt, Wayne Chang, and Olumide Danisa, titled Mitigating Malpractice Claims, Practices for Healthcare Professionals, from the May-June issue of SpineLine. You'll have the pleasure today of hearing directly from Jacob and Dr. Danisa, and our hope and goal is that this discussion will further expound on their compelling article that was published in the journal. Before we get too far into it, I want to give both of our guests today an opportunity to introduce themselves and tell us a little bit about themselves and their background.
Thank you, Dr. Barkoh. My name is Jacob Razzouk. I'm a medical student here at Loma Linda University, and I'm very fortunate to have the mentorship and guidance of Dr. Danisa here, who has allowed us to write this article for you today.
Thank you. Thank you, Jacob. I'm Olumide Danisa, and I'm a spine surgeon. I'm director of the spine here at Loma Linda, joint appointmentship at the university with orthopedic surgery and neurosurgery, and also vice chairman of orthopedic surgery. And actually, another thing I'm very proud of has been a member of NAS for over 21 years.
Awesome. Well, thank you both for being on. And such a great article, such a great topic. As a practicing spine surgeon, malpractice is something that we run into at some point in our career, but a lot of people treat it like the boogeyman, right? Like we don't want to talk about it. We don't want to think about it. So what a great and timely article, really something that we could focus on and really learn from. So as we're getting into it, let's start by establishing some definitions so that everybody's on the same page as far as our listeners go. Can you guys briefly define what medical malpractice is and also define the term negligence?
Yes. So medical malpractice is an action or sometimes a lack of action by a medical practitioner, whether that is a physician, a nurse, a physical therapist, that falls below the accepted standard of care that would be provided by similarly trained practitioners. A related term, negligence, is a breach of duty by a practitioner on the part of the practitioner that results in causation of injury to the patient. And it's very important when qualifying these terms that what constitutes medical malpractice or negligence varies across state to state. It's not established at the federal level. So what may constitute medical malpractice or the quote unquote accepted standard of care in a more rural region may be different from that in a more metropolitan area. So it's just important for all the listeners out there to just keep in mind and be aware of what the standards are in one's local region.
So, just to add to that, for what Jacob said, definitely it's there's no real hard and fast rules. I think it has every state, as you were saying, state with their own statutes what defines malpractice or breach of duty. So, I think it's good for us to have an idea as practitioners what malpractice is and what accepted standard of care is, and how we either violate or fall below those standards, and be very aware from our patient standpoints, from our own professional standpoints.
Those are great points. And I think that's something that's really important, particularly for not only for all surgeons, but for young surgeons as well. If you practice or trained in one area and you're going to practice in another area, you got to tap into the local community there and really understand what's going on locally. That will affect not only from state to city kind of standards of care. So those are great points, great definitions. So, as I mentioned earlier, many doctors kind of avoid thinking or talking about malpractice. What are your thoughts on that? Is that a good idea for practitioners to do?
Well, it's interesting now. Things have evolved. Speaking as someone who's in practice for over 20 years, and the treatment from even our education from medical school and residency, and now we can even see, depending on what state you're in or whatever. Even through residency, we are exposed. If you're going to do something, or a practitioner, or of some. We are exposed to malpractice even as residents. Actually, personally for me, I was involved in a malpractice suit when I was a resident that I had minimal contact with the patient. And whether as a resident or as a practitioner, none of those feelings, when you have, it's almost always for us as the recipient of those claims or so, it's almost always a negative feeling. And so like in humans, we tend to shy away from negative things, hate to talk about them, rather than, when we have in meetings, such as NAPS meetings, where you say, what is my worst case? I mean, we're all happy to talk about it, but when we're under the scrutiny and the spotlight of poor care or below standard of care, we tend to shy away from that.
Right. And while it's certainly probably a less than desirable topic to address, it's a reality of clinical practice. And we live in a very litigious society. So I think just with everything in life in general, the extremes are not the most constructive courses of action. So while being overly obsessed or paranoid with malpractice or sweeping it under the rug, those two extremes are not the most constructive courses of action. And as we're going to talk about in this podcast today, learning how to practice in a way that mitigates causing malpractice is of benefit to both the physician as well as the patient, and can teach and empower practitioners to be able to provide their patients with excellent care, and to the patients that we serve.
No, I think it's a great point. And to piggyback off of that, as you said, I think when you keep the focus on the patient, neither of those extremes really make sense, right? On one extreme, if you're not really paying attention to the standards of care, not really paying attention to how that ties into malpractice, you're maybe not providing the best care for your patients. And on the other extreme, if all you're focusing on is avoiding suits and maybe adding additional tests and studies and different things because you're afraid of being sued, you're probably not providing the best care for your patient either. So I think that's a really great point that you mentioned, that, you don't necessarily want to gravitate towards any extreme, but I recognize it as a reality of being a practicing physician. Great point. So in the article you talk about, and Dr. Danisa, you kind of hit on that a little bit, as when you are the recipient of the lawsuit, things change a little bit. And you mentioned that in the article, that the roles change during a malpractice claim. Let's talk a little bit about those roles and how they can affect the physician a little bit further.
Well, most of us as physicians, we're depending whether you're a surgeon or a medical doctor, a physical therapist or whatever, we tend to be the providers, right? So we're the provider. When we're filed with a suit, that our roles kind of change, because not only are we no longer the provider, that also changes our relationship with the patient, because then we become almost like civil combatants, right? And then the patient becomes the plaintiff and we become the defendant. And as you say, so our role changes somewhat. So, and we have a little less control. We have a little less, input in the outcome, unless we've done some stuff and done some things in the prior to this. So that's not our comfort zone, being a defendant rather than the provider. So that changes us, and we're kind of in a limbo or a no man's zone, knowing where do we act, because not only do we no longer have the relationship with the patient, or it's soured, we have litigation, we have the law, there's civil law, we have attorneys, we have mediation, other parts of it who weren't there at the beginning. So that has really set the stage for a different relationship with the patient, and also our relationship and how we see ourselves.
Absolutely. And I think that really lends to that discomfort that we talk about, right? Being in a new space, at least for me, and I'm sure many other practitioners will agree. Like, I like things the same way, whether it's in the OR, like I have a routine, I have a flow, and this, for your practice is a change in flow, right? It's a change in role and change of position. And I think it really adds to the discomfort and why people get so uneasy about it in general, being in a new role and new position, for sure. The article talks about neurosurgery having the highest claims per 1,000 physician years. And you also discuss talk about some of the financial aspects and the barriers to enter a claim versus potential reward. Let's explore those numbers a little bit. And do you think that cost of entry affects the number of claims that ultimately get filed?
Right. So to file a claim only costs about $100 to only $500 at the most. Now, expenses will rapidly start to accumulate as attorneys and expert witnesses become involved, and the whole process starts to kick into gear. But the potential gain from those invested costs can be many times that the average indemnity payments for a settlement versus a plaintiff verdict ruling are larger for the settlement. So whereas settlements can range from $2.3 to $5 million in compensation on average, verdict rulings for the plaintiff only range about from 1.3 million to 2.5 million. So that can certainly influence one's decision when the barrier to entry is only $100.
Now, I thought that was a really interesting point in the article, and obviously, and we'll get into it. There's multifactorial, right? Why somebody might file a claim, but that barrier to entry was an interesting point that you guys noted in the article. It's something that was eye-opening for me. I didn't realize that that $100 gets the ball rolling in certain situations. But you also talk about the secondary costs of malpractice claims. Explain that a little bit more for our listeners.
A malpractice claim can really shake the physician to the core. There's no other way. 50% of physicians will experience self-doubt or a loss of confidence following a malpractice claim, and over 1 in 4 will develop depression. And a malpractice claim contributes to increased practice of defensive medicine tactics. And even without considering, the effects of a malpractice claim, spine surgeons already are 300% more likely than non-spine surgeons to practice defensive medicine.
And even before you even talk about the issues of just even money and things like that, but think about, as you said, first of all, starting off with, a couple $100, and then just sets up this inevitable cascade. Most malpractice things, everything happens. It's not like you're reinventing the wheel. They have a certain cascade from filing a claim to the attorney, speaking with the attorney, and those are billable hours, getting expert witnesses, looking through files, getting subpoenas of records. So all of this is just adding to it. And not only thinking about this, thinking about what happens to defend you. So speaking of your attorney gets expert witnesses. And even when you win the case, even if you win the case, you have this thing called the lost run report, which means that what it costs to defend you. And then that also spills over into things such as your malpractice insurance, your ability to be able to get licensure and hospital privileges, and more importantly, actually the longevity of the surgeon, things like what's coming in play. 20 years ago, no one talked about physician burnout. This is a palpable issue with the stressors for physicians and healthcare workers with burnout and depression. And when we talk about the non-compensatory issues such as issues not only at work but at home. So there's a money factor into it, or financial factor, which is tangible, but also how it tangibly affects the physician's productivity, physician's well-being, basically.
The duration of a lawsuit, on average for a settlement, it's 3.5 years, and for an actual verdict ruling is 5.5 years, which this whole long drawn out process can wreak a vicious emotional toll on the physician and cause them to feel a range of emotions, from, as Dr. Danisa said, being totally fed up to experiencing those sleepless nights of tossing and turning in a cold sweat, to experiencing emotions of bitterness, of betrayal, of anger, and just burnout.
Yeah, those are great points, and I think those numbers and statistics are staggering. As you said, that 300% difference, that 25% risk of depression, and I think to both of your points, Dr. Danisa, as you mentioned, the alarming rates of burnout amongst physicians. These are all factors that I think that's why this article is so timely and so important. It all plays into that bigger picture, as why are we seeing so much burnout? Why are people leaving the field or retiring earlier or transitioning to other either models of practice or using their degrees in other ways, whether it's working for pharma or industry or whatever else. I think this is a factor because, as you said, it can shake you. And I think looking at that, that's a 3 to 5 year cloud that's hanging over you, right? And it's, it might not be something that you're thinking of every day, but there's going to be moments, week to week, month to month, where you're dealing with that, and that really, really can add to the weight that's on you, on top of trying to provide quality service to your current patients and dealing with surgeries and complications and clinics and paperwork and admin stuff. So it's definitely a big deal, definitely an important topic and something that's really, I think, contributing to that burnout for sure.
As Dr. Danisa was saying, the scope of indirect costs is a lot larger than just the monetary expenses associated. And I mean, we could go on and on about all the opportunity costs and those hard to quantify costs associated with all the stress and time in the courtroom.
No doubt. We'll circle back to that at the end. I have follow-ups, but I want to, keep us on track, focus on the article. So I won't diverge too much. So we talked about kind of setting the stage, some of the background, why this topic is so important, the direct and indirect costs, that spine surgeons and neurosurgeons that were some of the highest claims per 1,000 physician years. So I want to shift and talk about some of the recommendations that the article has that you guys present to lower that litigation risk. And so the first one was establishing a relationship. Let's talk a little bit about the importance of establishing a relationship with patients.
Well, I think that's, I think it's really hard to place it in outline form because everything kind of comes back to that. You in anything in life, when you meet someone and you know how important relationships are, and we have relationships with our family, with friends, significant others. It's just the same as with a patient. Unlike with our family or friends or a social relationship, the relationship with a patient is a little strained in the sense of the patient comes to you because they need help from you, whether it's in the spine, they're in pain or whatever. But the thing is, we also have the time constraints of running a busy practice. It's very important, and there's no better time than with the first meeting when you can, so the patient gets to kind of enter a relationship with you, whether or not they like you. And then they say they can, then with the like, and they have a discourse, then it depends about trust. Obviously, patients, when they see you, most of them expect, and they already think you're pretty smart. So it's not really a reason for us to say, hey, I have to prove myself to this patient, say, I'm a smart guy and you should have surgery by me. They already know that, but do I like this guy? Do I trust this or this physician? Will this physician do his best for me? Does he explain things to me? And so they have a comfort level. Once you have that comfort level, then we base everything on that. So when, and most of us know, when things go wrong in a relationship, you still go back to that where there's some established trust. If you have trust with someone, there you have the ability to say, he explained this, or even if something bad happens, this person did everything they could to help you. So I think really it's a way to make sure we understand. It's not to teach people, but to understand that the relationship is very important. And you have to not only understand that, but knowing that while we're still running a very busy practice, the phone is ringing, you're having consult, you have a lot of cases. And so we don't rush into it. We actually put the time into that relationship because that really can save you. And also for when they're not only in good times, but in expected times, but sometimes when things go wrong.
That's a great point. And I'm going to butcher some of these facts. So for those fact checkers out there, fact check me on this. But the general idea, there's data and articles that have come out that says, we interrupt patients within, I think, 10 or 15 seconds of them starting to talk. The perception of how long a patient-physician interaction was based on whether you're standing or sitting in a room. So there's a lot of little things, to your point, Dr. Danisa, that we can do that can help build that relationship, even with the busy practice. I had a mentor once tell me that he treats his practice like he treats his marriage. He apologizes a lot. So anytime he walked into the room and he's late, I'm sorry, I'm running. I know I'm behind. I'm sorry. And that kind of diffuses that tension, and to your point, builds that relationship. And that's really the foundation. So I agree 100% with that. I think that was really, really great point and well put, both directly and in the article. You also talk about performing the informed consent and what information should be included and documented in that consent form. I thought that was really great points. Let's speak on that a little bit.
So the biggest things for the informed consent, and you'll listen to various attorneys talk about, well, you want to have all of the risks detailed there so that everything is there for the patient to see. And then some will say, well, if you do that, then the one time something outside, some anomalous occurrence happens, that, you kind of have breached that informed consent. But the main overview is to have some sort of talking about the risks, the benefits, the alternatives. And another important aspect is the realistic expectations, and really, especially in the field of spine surgery, the realistic expectations and the realities that, unfortunately, despite all our advances that we've made in the field of medicine, you can't always make everything perfect.
So, there, not to be hokey or anything, but when we talk about your relationship and the communication and with the consents is this, I use the terms: I initiate the relationship, I educate, I communicate, and I relate to the patient. So those are the things that I think that are important. So when you talk about informed consent, sometimes—
Danisa, say those again, just for our listeners so they can write them down. You initiate.
I educate, I communicate, and I relate to them. So those are the things I think I try to do, and with every patient too. So obviously we try, as you say, it's a practice, but in that way, I feel that I've given my all. But also when we talk about informed consent, you try to educate them and say, this is what's going on. This is what can happen from the surgery. And especially when you have a relationship, you know what kind of expectations they have. You cannot just sign someone up on the first time and say, well, you don't really know, because they may have expectations that you cannot deliver. And the only way for you to know that is if you have a relationship with them. You'd be shocked what some people expect. And then I say, hey, I know this is what I can give you from my experience. If they say they're not comfortable, then think really long and hard about pursuing that relationship and going ahead with that surgery, because you may never be able to make that person happy. Now, with informed consent specifically, you have to understand that sometimes we give them information overload. So one of the things I try to do with informed consent and consent is I really try very hard for them to have family members or significant other or someone there to also hear for a second set of ears, not for me, but for them. But then you give them an overview, what specific to the surgery or procedure, but also things that may occur. Now, it's not enough it's still not carte blanche. It doesn't give you carte blanche to say, well, I told you this could happen and it did happen. And I think we even talked about that in the article too, the delivery of that information with respect to timing is everything, where if you educate them and talk to before it, it's called, you are explaining. An explanation is different from what?
Right. The difference between an explanation and an excuse is timing.
Basically, yes.
I like it. No, I think those are great points. And as you said, Dr. Danisa, it's practice. I think one of the things that you realize when you take a step back is that oftentimes we've been inside our medical bubble for so long. The way that we talk to each other, we assume everybody understands what we're saying, right? And so we start throwing out things in our consent about durotomies or something else. Or if you run through that and you stop and you ask them, hey, what did I say? A lot of times they're like, no, I missed it all. And it's not that they weren't listening. It's that we weren't speaking to them in a way that they can comprehend and on their level. And I think as you grow and mature in your practice, you start to recognize some of those nuances. And as you said, you try to relate more to the patient so that you can provide them with true informed consent. If it's not really informed if they don't understand anything that you're saying, as far as the risk, for sure. So great points. So I'm gonna see if I got it. We initiated, we educated. There was a C, communicated and related. There we go. I got it. All right. See, we're all growing here today. This is awesome. Moving on to the next question. At the point in the article, you talked about the importance of competence. What should physicians do to minimize misdiagnosing or delay diagnosis or any technical or procedural errors that might come up?
I think the short answer is to just take the extra seconds and to take pride in the details and to take pride in being thorough and to really doing things that are within one's locus of control to do and to make sure is, there's surveys where 60% of spine surgeons say they have performed a wrong-sided or a wrong level surgery. And that is an entirely avoidable practice. And all over 50% of incidences where a wrong level or a wrong-sided procedure is performed, it leads to litigation. So that is one easy way to avoid a malpractice claim landing on your desk, is just by paying attention and taking the extra seconds to go over things that don't require any professional knowledge. The procedure is difficult enough, so there's already a ton of technical difficulty. So taking care of the easy stuff that doesn't require any technical expertise, just a little bit of time and attention to detail.
So to add to that with what Jacob was saying is that a lot of people have used corollaries when we do procedures to the airline industry, where we do checks and double checks, right? So where, when you have a pilot and he's about to fly a plane, he has a checklist with the co-pilot before he starts. And we've been doing that through my history with the national initiatives. I was on the thing about SignMark site. About a decade ago, we were talking about trying to get all these surgeons, neurosurgeons, and orthopedic surgeons talking about, for example, we take an X-ray for just even a laminectomy. How many X-rays is enough? Some say one, some say none, some say I do it 2 or 3, and we have to. So we actually came up about it, and we've had the NAS and the AOS people with attorneys and say, well, you can't do this, you can't do this. You're boxing people in. But what we need to do is have in your own mind a set of checklists. So before you take off and fly on that plane and know to make it the safest flight you can. Now, talking about late and delayed diagnoses and tests, well, that's something that you have to put in part and parcel of your practice. So when you order something, follow up on it. And some of that is helped by the fact that, for example, in our institution, we have something, we have a computer data set. So when I order a test within our system, I have to sign off on it so I see it, and it tells me real time when I saw that study and I check it. So try to put that. So just don't order or give it to somebody. If you order a test, we are actually very liable and responsible for that test. I mean, and I'm sure you've seen too, when I order an X-ray of somebody, the radiologist will call me and say, hey, there's an incidental finding of a lesion in the lung. And he checks off that and he even documents, I spoke with Dr. Danisa about this, and he goes, I'm done. So then it's up to me to kind of talk to the patient and say, yeah, I'm talking about your hardware, but there's a lesion that we found out in your lung. So maybe you have to get that checked out. So for us, when we do tests, we're busy. Make sure that you follow up on those tests, because you know what? The patient knows you ordered the test. If you at least owe them the courtesy of following up on it and letting them know what we found.
Dr. Danisa put it in very simple terms to me one time. He said, if you're going to take the time to order the test, then follow up on the test. And I mean, the procedure is going to be difficult enough. So you might as well perform it on the right side or the right level. And I guess probably some of the listeners here are saying, okay, that's nice. You guys are sitting in an office talking about it. The pressure's not on it. It's not game time right now. But just another analogy, like you're driving a car, you're going 80 when you should be going 65. And you're only going to save maybe a minute, 30 seconds at best. But if you get pulled over by the cop for that, and you get a ticket, and then you have to go to traffic school, by just staying in the 65 and taking those extra 30 seconds, you save yourself all of traffic school. And I'm definitely not speaking from personal experience, but yeah.
No, I think those are great points. I think, at least in my opinion, the wrong level is always a worry in the thoracic spine for me. Yeah. And that's one area where, on post-op imaging, depends on, are you counting from the top down or from the bottom up? And are those things consistent, or is there a hypoplastic rib or something like that? So that's always challenging. But I think the key to your point there is to try to be consistent and document your logic, right? So I counted from the bottom up, matching what I saw in the MRI where I counted from the bottom up, and this is what I'm identifying as T9 or 7. So I think I agree with you 100% with taking that extra time, but also taking that extra time sometimes in documentation of your thought process, particularly for me, in my practice, the thoracic spine is typically the trickiest. And then to your point, left side, right side, hopefully we are all have been drilled into our heads to initiate the timeout, to talk through that. And that's that checklist time where we're all stopping and saying, okay, hey, we are doing a right-sided 4 or 5 microdiscectomy. I've marked the right side. I'm standing on the right side, and we're ready to go. So great points about that extra time, because as we mentioned earlier, going too fast might earn you 3 to 5 years of litigation that you have to deal with off of saving 2 minutes, in the OR. So great points. So you also mentioned some considerations about modern technology and social media and how that might factor into potential malpractice risks. Let's talk a little bit about that.
Well, it's interesting that we talked about that. We had, I think it was in either JBJS or the JAOS, we're talking about social media and its effect on in our practitioners. We're in a new era now of social media, looking at things like not necessarily like LinkedIn or our own specialty, but like even advertising for patients. So there are doctors starting to practice an easy way. In the old days, an easy way was take a lot of calls and you got patients. But now people are a little bit more sophisticated. You can see the younger generation. So doctors are putting stuff out there on Instagram, Facebook. But the problem is sometimes when you get that, it's kind of a soft area. Where does the physician-patient relationship initiate? And sometimes on social media, there are some rules and not rules, sharing personal health information. And so those are all new things that are coming into legislation. And actually with state rules and state medical licensure, we kind of are in the gray zone, and you have to be kind of careful because that stuff is really exploding faster than we can do, and even faster than case law, actually. So, there are certain platforms like, for example, there are physicians who almost advertise it, because that's a great way to reach patients, a great way to initiate and things about your care. But you have to be careful. For example, if you advertise and post pictures, for example, and if someone gets identified that way, or if you give information or give advice. So there are actually these articles actually say, if you do that and someone reaches out to you, you say, I'm not going to go any further, and then come and meet me, and you can meet and we can discuss. And then you have a true initiation of a patient-physician contact. And then that starts off the patient as your patient rather than just talking on social media.
Those are great points. And then also, I've always wondered, to your point about initiation, your license too, right? If I'm licensed in Texas and somebody's reaching out to me through social media in California, how does that play out as well? So there's a lot of dynamics to it that are interesting.
Right. I mean, it's a very exciting way to get to people, and the way to kind of broadcast your talents to several people, or even to explain certain things. Unfortunately, a lot of things on the internet may not be from a licensed practitioner, so you have to be somewhat careful. And for someone who is knowledgeable like you want to say, "Hell, no, that's that's incorrect. This is how it really is. But, for example, being a spine surgeon, you say, oh, look at what I've done to this person. This person was really crooked. Now they're straight. I mean, we have that in LinkedIn, which is a little more protected. We have that in our own, doximity for us as physicians to do. But when you use it with the general population, and even when we think of things like, Instagram, when there's only around for like, or Snapchat, they're only around for 24 hours. Unfortunately, in social media and into the internet, it's actually out there forever. So we have to be careful about that and be very careful. So my thing is then, if you do not know, either talk to, if you're in an institution like I am, you talk to the institution and talk to the attorneys, and they'll give you what they know so far. But even that's evolving. If you're in private practice, that may be a little more tricky, and you really need to be very careful. Each state has it. Their recommendations. So I would, if you're going to engage in that and to be a major part of your practice, I think you should be very careful how you interact with patients that way. Now, a lot of people, that's how patients, if you're going to be communicating with patients through the internet, then make sure someone is following up. For example, if a patient is, instead of calling the old-fashioned way, calling your nurse or medical assistant, if they're calling, but if they're emailing and you have that open, make sure someone's answering it rather than not answering, just blank. So if you have that capability, make sure you have someone who's responsible for responding to it in a timely fashion. And even if it's not you, designate that person and then spend the time with that person so you respond appropriately to the patient.
Oh, great points. Great points. Well, thank you both for your time. I think that about wraps it up for us. Are there any last takeaway points or any last topics that we didn't cover that you guys want to mention before we wrap up?
No, I think, I'll say this. I think the article was meant basically for this. We spend a lot of time learning how to perform procedures, how to be great surgeons, and our patients think we are. And for the most part, they were competent, good surgeons. But a lot of times, I think when we have to be mindful of things when things don't go well, how we can be better doctors by not only being excellent clinicians and practitioners, but also to understand the less tangible things in medicine, such as communicating with patients. And also, I mean, it really is an art form of communicating even bad news to people, because, if you're seen as an unfeeling or detached or distracted person, that's not a good light. And that person's not going to look at you with a positive light, especially if things aren't going well.
Right. Absolutely. Absolutely.
The key things to take away is that when we're talking about mitigating malpractice, this by no means minimizes the pain and suffering of patients who have experienced malpractice. Malpractice can result in devastating and heartbreaking consequences for patients. So that is important to emphasize. And it's also very important to emphasize that by practicing in a way to minimize causing malpractice is of benefit to both patients and physicians. And so it is our duty to conduct our practice in a way that establishes a relationship with the patient, to practice in a way that is with integrity and that earns the respect of the patient, to communicate clearly and on time, and to document thoroughly, because if it isn't documented, then it didn't happen.
I think those are all great points for sure. So I believe that wraps up the questions I have for today's podcast. I want to thank you both for your time, to Jacob Razzouk, to Dr. Danisa for being on, to all the listeners who tuned in. We're thankful for you joining us today on our NAS Public Affairs podcast. I'd like to acknowledge the help from our wonderful behind the scenes NAS staff members, which make these podcasts possible: Jeff Karzan, Pamela Town, Brianna Schaefer, as well. I am Dr. Kaku Barkoh, signing off from Houston, Texas, and don't forget to stay spine safe out there. Thanks for joining us.